ETCM, the emergency medicine channel. So in last video, we discussed in trauma in pregnancy, what's the anatomical and the physiological alterations. So now we will discuss the what's the mechanisms of injury and the what's the how will you assess and how will you treat the pregnant woman. So the mechanisms are mainly the motor vehicle collision, fall, assault, gunshot wounds and the burns. The percentage is the for the motor vehicle collision 49% and the falls 25% and the assault 18% and the gunshot wounds 4% and the burns will be the 1%. And next one is the distribution of the blunt and penetrating abdominal injury in pregnancy. So the mechanism as a blunt is in 91% and penetrating is account for 9% in penetrating. So the gunshot wound 73%, stab wounds 23% and shotgun wounds 4%. So this is regarding the mechanisms of injury in a pregnant woman. So next one regarding the blunt injury. So the mostly in blunt injury, the abdominal wall and the uterine myometrium and the amniotic fluid. So these all things will prevent the fetus by direct injury from the abdominal trauma. So the abdominal wall and the uterine myometrium and the amniotic fluid, it acts as a buffer to direct fetal injury from the abdominal trauma. So if you are seeing any external contusions, aberrations of the abdominal wall, it's a signs of possible uterine injury. And the shearing force, it results the abruptio placenta. And the next one, so in collision, if we are compared with the restrained woman and unrestrained woman, so unrestrained pregnant woman has a higher chances of premature delivery and the fetal death. So in collisions, so in any trauma, so the compared with the restrained woman, unrestrained woman, she is having the higher chances, so higher risk of premature delivery and the fetal death. So first thing, how will you wear the seat belt? So how to wear the correct? So it will be the lap belt, it should be so below the belly and flats on the top of the thighs, and shoulder belt should be in between the breast. So shoulder belt should be in between the breast and the lap belt should be below the belly and it flats on the thighs. So next in the penetrating trauma. So in penetrating injury, so in anatomical alterations we already discussed. So this enlarged uterus, it pushes the viscera into the cephalad side. That's so mostly the maternal visceral organs. So maternal visceral injuries accounts for the excellent maternal outcome in case of the penetrating trauma, and but the fetal outcomes are generally poor. So in gravid uterus, it grows larger. The viscera are relatively protected from the penetrating injury and the low incidence of maternal visceral injuries. So that's why the maternal outcome is good when compared with the fetal outcome. So fetal outcomes in penetrating trauma is generally poor. And next one is how will you assess and treat? First thing, the assess and resuscitate the mother first. So after stabilizing the mother, we can assess the fetus before conducting a secondary survey of the mother. So assess and resuscitate the mother first and then assess the fetus before conducting a secondary survey of the mother. So what are all the important things in primary survey of the mother? So the mostly if patient requires the spinal motion restriction, just in the supine position, log roll her in the left 15 to 30 degrees. It's a diagrammatic representation and ensures that patent airway and give the adequate ventilation and oxygenation. Provide adequate ventilation and oxygenation and effective circulatory volume. And next, if patient is requiring the ventilatory support, so intubate the patient and maintain the PaCO2 level at the 30 millimeters of mercury. We already discussed the hypocapnia, it's a normal in the pregnant woman. So we want to maintain the PaCO2 of 30 millimeters of mercury and manual displacement of the uterus already. So to prevent the pressure over the inferior vena cava. And because of increased intravascular volume, the pregnant could not show the signs of hypovolemia, but it may lead to the placental hypoxia. We can see the fetal distress and all. So we can administer the crystalloid fluid resuscitation and early specific type of blood to support the physiological hyperolemia of the pregnancy. And the vasopressors, this is a last resort to restoring the maternal blood pressure, because if you are giving these vasopressors, it further reduces the uterine blood flow. So results the fetal hypoxia. So that's why the vasopressors are the last resort for the restoring the maternal blood pressure. And we want to take the baseline laboratory, and it includes the fibrinogen levels. So fibrinogen level is doubles in late pregnancy. So you may think the normal level maybe indicates disseminated intravascular coagulation. Next, in the fetus. So after stabilizing, after primary survey of the mother, if mother is stable, so then we will assess the fetus before the secondary survey of the mother. So in fetus, the main cause of fetal death is maternal shock and the maternal death and the placental abruption. So maternal shock, maternal death and the placental abruption. And what are all the things we can see in the abruptio placenta and the uterine rupture? So in case of abruptio placenta, so there will be a vaginal bleeding, uterine tenderness, frequent uterine contractions, uterine tetany and the uterine irritability. In case of uterine rupture, so abdominal tenderness, gotting, rigidity and the rebound tenderness, especially there is a profound shock and easy palpation of the fetal parts, because there will be a uterine rupture, so we can easily palpate the fetal parts. And in most of the cases, so in most of the cases like in abruptio placenta and the uterine rupture, so the patient may report the abdominal pain and the cramping. So if patient after trauma, any pregnant woman, if she is complaining of abdominal pain and the cramping, we want to suspect the abruptio placenta and the uterine rupture. So, and next one, perform the continuous fetal monitoring with tocodynamometer. So, beyond the 20 to 24 weeks of gestation. So, the continuous fetal monitoring is needed. So, patient, here we are dividing the categories into two. So, patient with no risk factors of fetal loss and the patient with risk factors for fetal loss. So, patient with no risk factors needs the continuous monitoring for 6 hours. For patient with risk factors for fetal loss, the monitoring for the 24 hours. So patient with no risk factors need the continuous monitoring for 6 hours, and patient with risk factors 24 hours. So what is the risk factors? Or the maternal heart rate is greater than of 110, and the injury severity score is greater than of 9, and any evidence of placental abruption, the fetal heart rate of greater than 160 or less than 120, and pedestrian collision. So ejection during the motor vehicle crash. So in assessing the fetus, so we want to do the continuous fetal monitoring with tocodynamometer beyond the 20 to 24 weeks of gestation. So the patient with no risk factors for fetal loss needs the monitoring for 6 hours. Patient with risk factors for fetal loss need the continuous monitoring for 24 hours. So what's the risk factors are? The maternal heart rate greater than 110, injury severity score greater than 9, and evidence of placental abruption, the fetal heart rate greater than 160 or less than 120. So pedestrian collision and the ejection during the motor vehicle crashes. So these are all the risk factors for fetal loss. So after assessing the fetus, we can go for the secondary survey. So secondary survey in pregnant is same as the non-pregnant. So system-wise examination we can follow. So and mainly the important things in the secondary survey. So evaluation of perineum includes a formal pelvic examination. It should be done by skilled obstetrician, and the presence of amniotic fluid in vagina with the pH of greater than 4.5. It suggests the chorioamniotic membrane rupture. So ruptured chorioamniotic membranes. So the presence of amniotic fluid in the vagina with a pH of, it's a pH of greater than 4.5. It suggests the ruptured chorioamniotic membranes. And note any cervical effacement on dilatation, the fetal presentation. So you just check the any cervical effacement, dilatation and the fetal presentation. And if patient is having the vaginal bleeding, vaginal examination is vital. So but repeated vaginal examination should be avoided. So if patient is having the vaginal bleeding, vaginal examination is vital, but we can't repeatedly, we won't do the vaginal examination. So All pregnant with Rh negative trauma patients should receive the Rh immunoglobulins. So it should be instituted within the 72 hours of injury. So all pregnant with Rh negative trauma, or all pregnant with Rh negative trauma patients should receive the Rh immunoglobulin, that's a 300 gram IM. So 300 gram IM, it should be instituted within 72 hours of injury. And in case of maternal cardiac arrest, so in case of maternal cardiac arrest, you just follow the BLS and ACLS. So give the high quality CPR and give the indicate like if it is indicated defibrillation, and then give the injection epinephrine. So perimortem cesarean delivery. So if no ROSC, we can perimortem cesarean delivery within 4 to 5 minutes of cardiac arrest. So see, this is in the secondary survey. So in secondary survey, mainly the same as the non-pregnant, but the main important things is the pelvic examination, which will be performed by the skilled obstetrician, and the presence of amniotic fluid in the vagina with a pH of greater than 4.5. It suggests the ruptured chorioamniotic membranes, and note any cervical effacement, dilatation, and the fetal presentation. So if you are seeing the vaginal bleeding, so the vaginal examination is vital, but the repeated vaginal examination should be avoided. But all pregnant with all pregnant Rh negative trauma patient should receive the Rh immunoglobulin within 72 hours of injury. That's a 300 grams IM. And the maternal cardiac arrest, so usually follow the BLS, ACLS, and the high quality CPR. And the next one is the drugs, and if no ROSC, the perimortem cesarean delivery within 4 to 5 minutes of cardiac arrest. So thank you.